I don't know. I haven't slept in 2 days, and now I got a little Bombay belly. So I'm going to run through these cases, but more so, I think Rick has a couple of cases too. And look, I really believe we are with osteotomy where we were with robots here 10 years ago. And I know in 5 years, because this is how Indians work, you know, their love of technology and being super smart. Like, I just see all these light bulbs going off, and eventually it's just going to be, they're going to have, you know, the Indus PSI system, you know? I just know it's going to happen in 2 years. I just want to say I was here when we first brought it to India. So let's do, okay, this is a 50-year-old, like he's a paramilitary SWAT police officer, and he's got this knee. 8 degrees of varus, medial OA. He wants to walk around and, you know, shoot people. Rick, you know, the 9/11 of India happened in Mumbai at the most famous hotel at the Gates of Pearl. And I remember one of the things that we learned from 9/11 is that we had bad systems of tracking airplanes. And I remember what the Indians learned, that their paramilitary was inefficient getting to the hotel. Was that, what date is that? November what? What was that? Yeah. Yeah. I'm a frustrated history professor. I'm trying to give Rick some culture, okay? He's a white guy from Montana. He doesn't know anything, okay? I mean, he knows a lot. He could tell you how to chop wood and like probably about like how to fish to Missoula. But, so, Rick, what do you do for this guy?
Well, I mean, it's an osteotomy talk, so.
What do you tell this guy?
Well, I think you need to be realistic about what his main complaint is. Many of these guys are, whether it's whether it's a police officer or whether it's security, former military who's doing contracting, they're going to pound on this knee. And so you need to, they'll take a little bit of pain, and if their goal is pain relief, just pain relief, I think a total knee is going to be the answer. But if their goal is to pound on this thing, which many of these guys will do, I think that this is, you're looking at an osteotomy here.
Why not a partial knee?
Well, I think there is a good argument for a partial knee. I think there is. It just depends on how hard he's going to, My whole thing was when you said SWAT officer.
Yeah, he wants to pound. He wants to run and chase guys and shoot people. He wants to do whatever it takes to get the most function out of his knee. He does not, he sees a knee replacement as grandma's operation.
He can join Indian police after knee replacement.
I didn't say he was a New York City cop. I said he was SWAT. That's different. Same in every culture.
You can shift him to India, no problem.
I think that you can argue this both ways. The problem is that if, depending on the amount of beating this guy's going to do and physical fighting this guy's going to do, I think your arthroplasty could be in jeopardy, where you wouldn't have that same risk with a osteotomy.
All right, so I want to run down the whole panel. We use a lot of, and Rick talked about it, a lot of fake, let's just say we decide osteotomy. We use a lot of fake cartilage. He had a full thickness metafemoral chondral defect, and he's got early wear of his tibia. Do I just do the osteotomy, or do I do something to the cartilage? Sachin, and go down the whole panel.
So he's got bone on bone on his x-rays. He's probably got bipolar bone loss there, bipolar cartilage loss. So for me, I'm not going to do an osteochondral allograft, but I'm going to do nano drilling along with a scaffold for his cartilage.
For his femur.
Yeah.
Yeah, I would do the same scopy and then do my nano drilling to the
And when you say nano drilling, are you saying a microfracture pick or a drill?
Drilling. Yeah. No picks, because microfracture with picks is bad. It doesn't penetrate enough to go beyond your subchondral layer. And the other problem with microfracture is that the impaction that happens does not allow you to have a good fibrocartilage, and you end up with an internal osteophyte.
You sound like you're part of the nanodrill consultancy agency.
Not really, but if you have a lead, let me know.
I do. Jason Coe invented it. I would say microfracture is bad. Nanodrilling is probably less bad in my hands. Rick, what about you? Is there a role for microfracture for cartilage wear in 2025?
There's some evidence that in an osteotomy, when you unloaded the joint, that actually did help. There's some publications on that. However, in this guy, I think that's gonna slow him down in his return, and he's gonna accept amount of pain. There's bipolar lesions. I would just do an osteotomy alone.
Isolate osteotomy. Next.
Bipolar lesion, I'll just go and do osteotomy and nothing else. If unipolar, I may add nano drilling and scaffold.
Only osteotomy in this case.
Only osteotomy.
Yeah, I feel his root is fine. There is no problem with his root. So if his root is fine, the cartilage, I think, as I totally agree with Rick, it will regenerate.
Why do you care about his root if his cartilage is gone on both sides? What is the root protecting?
Yeah, because
I get that if the root's out and his cartilage is there, I would say I'd fix the root.
the hierarchy for knee preservation is already set in. The first is alignment, second ligament, third meniscus, and fourth cartilage. We are talking about fourth element here. I am addressing third. Then we have to address second.
No, the
and
point of
first.
the root is to protect the cartilage.
Yeah.
So if the cartilage is gone, I wouldn't, I don't care about the root.
The Cochino study has shown, Cochino study has wonderfully shown that if you do an osteotomy and you retrieve the people who underwent osteotomy around 20 years back, the post-mortem dissection has shown wonderful growth of the cartilage. When you distract the knee joint, automatically it forms a hyaline-like cartilage.
I agree,
It
but that's
may
not what
be
you're
hyaline
talking,
cartilage.
that's not talking, that's talking, my debate here is osteotomy versus osteotomy and fake cartilage.
Yeah.
That's what you said the root. I'm saying the root here doesn't matter because the cartilage is gone. But I agree with you. So this is the age-old debate. I debate the Europeans every time because they'll say what? Osteotomy only, and you stupid Americans walk away. And we say osteotomy only and put some fake cartilage because we get paid a lot from our cartilage companies.
Yeah,
I don't know if you have a bad tire, don't you patch the tire up and fix the alignment, Sachin? Or you keep the bad hole in that tire?
So Anil, last year we wrote a paper looking at a systematic review which said that should I add cartilage surgery to my osteotomy? And the answer is that the quality of cartilage regenerate that you get by adding a cartilage procedure is far better than what you get by an osteotomy alone. So yes, you should do something for the cartilage because you have the tools to give them a better result. Cochino study showed cartilage, but that was poor quality fibrocartilage, and they were correcting way beyond Fujisawa at that time, and that's not something that you want to do in today's osteotomy practice.
So a couple of things here is that I don't think you have to treat the cartilage because we all would agree, right? The osteotomy is much more bang for your buck than an isolated cartilage, right? We would all agree with that. Versus in the United States, not this patient, but there's a lot of 5-degree varus knees with an isolated needle thermoconduit defect. They get a cartilage procedure, and guess what? They all fail. But you know what? But then they go, oh no, it was the BioCart. No, I have to do NeoCart. No, I have to do Mama's Cart. I mean, there's always a cart out there, but none of the carts work. So we all believe the fundamental principles of osteotomy is where you get your bang for your buck. Isolated cartilage doesn't work. I think microfracture as an isolated procedure is a dead operation. I do believe in microfracture in conjunction with osteotomy. There's a lot of literature out there. In America, they don't believe it. I love microfracture on the tibia because there's really hard things to do on the tibia. There's no great cartilage procedure that you can even get to the tibia sometimes. And I would say I did this operation like 5-6 years ago. I'm doing less OCAs, but this guy had a lot of bone marrow edema. And I do think attacking bone marrow edema is the basis of our business. And osteotomy is really the best way to do it. Sachin, you something else?
Yeah, a question to you is that if you go back to his x-rays, which is the one that you put up, his preoperative x-ray, there you go. Does the condition of arthritis correct? Whether it's bone on bone or not bone on bone, influence your decision for the post-operative correction. Whom do you want to correct to neutral? 54%, 62%. Is the status of the cartilage in the involved compartment an important factor to consider?
Yeah, I mean, I think that'd be another question to ask the panel. So you're doing an osteotomy for advanced arthritis here and an osteotomy to protect a cartilage defect, maybe a 4 or a 5 degree varus knee. So one's 8, one's 4. Does that adjust your, Roshan, does that adjust your alignment parameter, your weight-bearing line?
No, I'll urge on more correction because I
So
want
you
to
mean
deload.
yes,
Yeah.
it does change.
Yes.
Right, so more arthritis, you want to overcorrect a little more.
Or correcting.
Would anyone disagree with that? No. Yeah. So yeah, I think we've all changed that Fujisawa being the one and only thing. That was for all x-rays like this. My whole point, and I forgot who was presenting before, when he presented that 3-year-old patient, 3 years too late, I'm saying, we're intervening earlier and earlier because cartilage surgery doesn't work. And the best way to get these athletes back is to do a small correction and then do whatever fake cartilage you need. All right. But yes, I agree with and I think the power of PSI is now we're getting so granular, depending on the cartilage procedure you do, whether you do a structural graft, an OC allograft, people will actually accept more varus than Andreas Gamal and Brian Cole will talk about this versus a Macy or a pure cell-based one that they would want to offload it even more. And I'm not saying we have great data to support it, but I just see just how the alignment, the total knee and the alignment guys, they're arguing every degree. We're going to get that way with osteotomy for every sub-indication. He went back to being SWAT. All right, so you got this guy. He's got a 13 or 14 degree varus knee. He has some deformity on his femur and some deformity on his tibia. He's a manual labor, but he has a hip replacement. What do you do, Sachin?
He's got an arthritic hip on the opposite side.
A little bit,
contour hip is arthritic.
but is that, you're doing a right total hip replacement? He
No,
comes
but-
in for left knee pain.
That's one of the reasons which is also causing left knee pain, because his hip is arthritic, his pelvis is tilted, he's got scoliosis. So we have to take all these factors into account.
So we're doing a right total hip and you're doing a spine fusion on him?
No.
You sound like you should
I'm
work at
just kidding.
HSS.
Okay, anyways. So let's break down his deformity. His LDF is 90, normal is 87, MPTA is 80, normal is 87 here as well. But I think I'm not going to try and correct his femur, which is 90. 90 is the outer limit. So I'm just going to do something on the tibia. I think he was something like 50 years old or something like that.
He's 50, yeah.
Yeah, he's 50. So I'm going to accept an LDFA of 90 and just do a high tibial osteotomy and try and bring the correction not going beyond 92 degrees on the MPTA. So I think the preoperative digital planning will tell me if by over-correcting the tibia to about 92 or 93, will I be able to bring his axis into neutral? And this is the power of doing digital planning. You know exactly what you're going to be achieving by doing that amount of correction, and you know the success of the operation before you actually commit to it.
Anybody, anything else? Anything different? So this was a very educational case because I did that. I did the planning software just on the tibia, and I felt like I had a big wedge and a big correction. So I decided to do on this guy, and that was a double level osteotomy. And it was early in my career because I was afraid of double level osteotomy. He tolerated this so well. He said to me, this double level osteotomy was just as easy as my hip replacement to recover. And that's what it is. Bigger corrections, 50-year-old guy, more time non-weight bearing, more likely to have a hinge fracture. It's just setting up smaller corrections. The limb just tolerates it better. It's a little more surgery for you, but it's a little easier on them. And that's what we did.
Do you get PSI guides to cut out your femoral allografts as well?
No, I mean, the best thing about doing a double level osteotomy, same reason why they do
I'm not
an,
talking about double level,
Oh.
but just say you're using a PSI guide, you're going
Yeah,
to be opening in excess of 10 millimeters, and you want to put in a femoral head allograft in
I
there.
used that with new clip, and it was just like, I could just take a saw and make a ruler, and I just zinged it. So I never used that.
What about you, Rick? You use a PSI guide to cut out your bone wedge?
The wedge, I use it to size my wedge, yeah. I mean, yeah, I do.
Anil, same case. Could you have achieved a similar result by doing only HTO rather than adding DFO? Just going back, I'm not criticizing your decision. I'm not at all criticizing your
If
decision.
you don't criticize me, then what's the point of the meeting? We love that.
Yeah.
It's called, we call that, I take care of a hockey team, we call that banter,
Banter,
or
yeah.
chirping, to chirp. No, my point was, he said his double level osteotomy was just as easy, and it was Amar's hip replacement. So maybe Amar was a bad surgeon, and he had a really bad, and my point is that the advantage of double level osteotomy is smaller corrections, soft tissue, easy to recover. Once you get anywhere near 12 or 13, as we heard, what happens to your risk of hinge fracture? Goes up. So my point is that this is, when I first started, I would never have done a double level. And my threshold to do double level are much higher because it's kind of like how my father said to us, when you're early in your total hip practice, do you know what you do? You put an extra screw in the acetabulum just so you can sleep. If you ever do an opening wedge osteotomy and you're not comfortable, you put a staple just so you can sleep. Double level now, once I never regret doing a double level, I only regret when I don't do double level on those, border cases.